this film is everything to do with posterior polar. We are bound to face this many times in our routine cataract surgery. So every step, like your incision has to be perfect. You can't have a small tunnel, you'll have a problem. Your CCC has to be well planned. It has to be smaller than normal, because in case you have a PC rent, you can do an optic capture in the CCC. Again, during phacoemulsification, reducing the bottle height and making sure you don't do your hydrodissection, do only a delineation, prevent rotation of the nucleus. Besides reducing the bottle height, whenever we come out of the eye during any step of surgery, make sure that we put in through the side port a viscoelastic so that the chamber is always well maintained. Never ever let the chamber collapse. So there are multiple steps to be taken during each step of cataract surgery in handling a posterior polar cataract, and that will be demonstrated in this surgery.
So this is another case which is a posterior polar cataract, and we all are worried about these cataracts. Patients have high expectations, but there are certain tricks that I'll show you in this case which can be adopted and you will do well and you can escape all complications. So step number 1 is a good incision, and make sure that you stain the anterior capsule. The reason I like to stain all posterior polars is that you have to make your rexes little smaller, because in case you have a complication you can do an optic capture and that will really center the IOL well. I always like to not hold the conjunctiva and just make the side port with the MVR. So having made the main incision and the 2 side ports, I am now going ahead and making a small CCC. I like to do my rexes always with the forceps directly and follow the image guided technology. Go all around and make the CCC. Of course, we know that the next step is a hydro procedure. In posterior polars, we do not do hydro dissection. So we always like to do a hydro delineation, which will separate the center piece. Throughout the surgery, all the precautions that I have taken will be shown. So you will be able to adopt the same during your handling of a posterior polar case. So step number 2, the hydro delineation. There is no hydro dissection. The golden ring slightly appears. Sometimes you can even create 1, 2 or 3 golden rings, and then you can stop at that. I have not done any nucleus rotation at this step. I have reduced the bottle height from 80 to 55, as you can see on the right upper corner, and then going ahead and just aspirating the soft nucleus which is there. Throughout, we make sure that the chamber does not collapse. So whenever one step is done, we go ahead and take a viscoelastic, fill up the anterior chamber, and then gently remove the phaco handpiece whenever your aspiration of the nucleus material is done. So you can see that the nucleus is entirely aspirated, and now what is remaining is only the slight cortical matter. So I'm not coming out of the anterior chamber at this stage, taking the viscoelastic and filling up the anterior chamber completely, and then coming out, and that will prevent any other mishap at that stage. So fill up the bag again, and now I always like to start my bimanual IA from the subincisional area, because in case we have a PC rent, that's the most difficult area to approach. So as you notice, I've gone subincisional and started to aspirate the cortical matter. Don't forget, we have not done a hydrodissection, so this cortical matter will be really adherent to all over the back of the anterior capsule after the CCC, the equator and the posterior capsule. The aspiration of the cortical matter continues till the center, but we make sure that the central part is not lifted. So we go all around. Again, once the port or the hands have to be changed, we make sure that we fill up the bag with the viscoelastic. At this stage, the bottle height is also kept low, and the bottle height is always kept at 50. Normally my bottle height that I keep is 80, and with this you can notice that I am going all around. And now we can tackle the inferior part, and this patient wanted a toric IOL, so we are trying to make sure that no other complication happens during this step, to make sure that the patient gets the best what they wanted. Once the aspiration of the cortical matter on one side is completed, don't forget, do not remove the irrigating port, and fill up the chamber with a viscoelastic. And now the posterior part is being separated gently. It did come up a bit, so I'm happy that it's not stuck. At this stage you can actually make out whether the posterior plaque is stuck to the posterior capsule or not. But at all steps one has to be very careful. So I'm just going all around, and when you see the posterior plaque floating around, be rest assured that this plaque is now not adherent to the posterior capsule and it is free to be aspirated completely. So I'm still not removing that. I'm removing all the cortical matter that is adherent to the equator, and now I go back for that plaque which is sitting there but freely floating. So I'm sure at this stage I've not had any complications. I'm very happy. And now you can see that we change of hands, we just go around and remove the rest of the cortical matter that is floating around, and that will also remove the plaque at the same time. Once we have achieved this, if there is any remnants of cortical matter remaining around the plaque, can also be handled. Sometimes one can use a cap vac mode to remove that. It all depends on whether there is cortical matter sitting around in the area of the plaque or not. But at that stage also you have to be very careful. You can still land up with a complication. So you can see the central area and cells all around it. That means the plaque was adherent but not that adherent to be able to come back with the posterior capsule. So this is just remaining cortex that is remaining near the equator. Gently go near the equator and then aspirate the cortical matter out. Again, the bottle height is maintained at the same level throughout. So we are not going to put in more fluid. The central area is crystal clear. And now I have changed my vacuum to cap vac mode. So the vacuum here is only 20. And I am aspirating the cells off from the posterior capsule, gently keeping the irrigation on. And one part of the irrigation is actually looking towards the posterior capsule. And we are just removing the cells from the posterior capsule. So you can see all the cells being removed. And the irrigation flow is towards the PC, which keeps the PC away. And the rest of the flow is towards the anterior chamber, which maintains the corneal endothelium layer. So this works very well, and this is entirely in cap vac mode. So this is very safe. By mistake, even if you hold the posterior capsule, it's really not going to aspirate out. Luckily, there was no complication, and at this stage one can then go ahead and implant the lens that the patient really wants. As I like to always implant an IOL under viscoelastic, I fill up the bag, push the posterior capsule away. I normally do not prefer to do a hydroimplantation. It all depends, and also depends on the injector that you are using and the kind of IOL that you are using. So this lens needs to be placed at 144 degrees. After a successful cataract removal, this is an EDOF IOL, and it's got special ridges on the haptic, which is known to help prevent rotation of these IOLs. So once the lens is placed in the axis, the viscoelastic is removed from front of the IOL, and the viscoelastic has to be removed from behind the IOL. As this viscoelastic normally gets compartmentalized in front and behind the IOL. So right now I'm going behind the IOL, nudging the IOL up, and one part of the irrigation is on the back of the IOL and one part of the irrigation is towards the posterior capsule. So this actually prevents the PC from coming up during irrigation and removes all the viscoelastic which is compartmentalized behind the IOL. So you can see some part of the viscoelastic which is close to the side port is also being removed. Once that is done, just rotate the IOL in the axis that we desire to place the IOL in. And once that is done, we just hydrate the wound. So this is one way one can handle with all precautions a posterior polar cataract. With modern laser technology, results are much better. Even if you have laser or an optical biometer, all this will help you.